Welcome to the Public Health Improvement Training sponsored by CDC's Center for State, Territorial, Local, and Tribal Support. I'm so pleased to be here with you today. My name is Laurie Call. I'm the Director of the Center for Community Capacity Development at the Illinois Public Health Institute, and I've been fortunate to help with planning FIT again this year. Feel free to introduce yourself in the chat by sharing your organization and location. We're going to kick off FIT 2021 shortly with information from Megan Wolfe. Say hello, Megan.
Hey, everyone.
On our platform. So we'll be kicking that off on our platform to help you get the most out of FIT. We'll also hear from Liza Corso.
Hello.
Hi. And our two opening plenary speakers, Dr. Jose Montero and Dr. Nafissa Egbuoyne. We're very excited this year because, as you can see from the map, we have many attendees. We have over 650 registrants from 47 different states, the District of Columbia, and 3 U.S. territories. So we're thrilled to have such a diverse audience today and participants. Those states who are shaded a bit darker represent higher attendance numbers, and we are so excited to have everyone. Let's get in some practice using chat because we're going to be using that throughout and start connecting with each other. So as you see the question on the screen, we'll ask you to please type your response to the following question in the chat. What's the most interesting thing you currently see in your workspace or your line of sight? And I think you all heard my most interesting thing. I apologize for that. So go ahead and type in the chat and let's see what you're seeing. Pinwheel, great. What else? Peach tree in my backyard, great. Multicolored Post-its, that's always there. Oh, a map of Pedernales Falls State Park, if I said that correctly. Day of the Dead paperweight. Great. Keep adding those in the chat log and we'll keep sharing. So what makes FIT different as you're continuing to type in? Some variation of the National Public Health Improvement Training has been offered by CDC's Center for State, Territorial, Local, and Tribal Support, or CSTLTS, for over 20 years. The focus has always been on skill building, regardless of the content or the format. And typically, many of you know, this has always been held in person. So participants have told us that they appreciate the application exercises, the real hands-on experience to determine how to apply the content and the skills in their work. And time again, we hear how important the networking has been, making connections to help further integrate the content and skills into daily practice through relationship building and knowing that help is only an email or a phone call away with someone that they connected with or a presenter or a national partner. So this year is no different, but it's very different. We have really tried to emulate some of the things that happen in person during this virtual experience. This is our first time going virtual, our highest attendance ever. We've over doubled our regular attendance, and we have more than 41 or many workshops, 41 to be exact. So we have more than we've ever offered before. New increased attendance, new formats, and we've really tried to be responsive to your feedback. People asked for more deep dives into some subject matter content areas, and so we're offering some deep dives. Those had been planned for longer sessions, but we're still going to offer those in a shorter but yet longer online capacity. Those will be Tuesday afternoon and Wednesday morning. And some of those deep dives are 2 parts. So you will attend part 1 on Tuesday and part 2 on Wednesday. And you'll need to attend both parts to really get that complete workshop. But we're also trying some new formats in the online environment. We have coffee chats, which will be smaller presentations focused very specifically on a situation or experience or skill that's been taught. And also some town halls where you can give some feedback and interaction with some of the national partners on different initiatives that are going on. So we are ready to make this year's FIT one of the best ever. We are so excited to have you and really looking forward to the next 3 days. So I'm going to turn it over to Megan now to help you navigate the platform a little bit.
Thanks so much, Lori. I appreciate it. So I'm just going to take a few quick minutes and talk a little bit about the different technology features that we'll be using at FIT in both Zoom and Pathable. So right now we're in a webinar format, so it might be a little bit different than the Zoom meeting format that you're used to. So you can probably see us, but not each other yet, and that'll change when we get into the workshops. But right now, as we've already been practicing, you can use the chat for any comments, introductions, as we go through this morning. Well, I guess this afternoon for me, but this morning for some of you. And then you can also ask speaker questions there. So as Dr. Montero and Dr. Egbuoyne are speaking, we would love you to have some questions for them in the chat that we can then ask them. Also, as we're going through the workshops, there will be different interactive features that some of the speakers will be using to facilitate the session. So those might include the reactions tool, the annotation tool, and other external collaborative tools to really increase interactivity in the session. If you have any trouble at all using any of those features or any other technical difficulties, every single session will have a room support person, and they'll introduce themselves in the chat right at the start of the session. So you can go to them at any time for help with any of those different pieces. So just a few quick slides about Pathable too. One of the tools that we really do encourage you to use in Pathable is the Saving Your Spot tool, so that you can reserve your spot in the sessions you'd like to attend. As Lori mentioned, a ton of people here this year, which we're so excited about, but that does mean the sessions are going to fill up pretty quickly. So to make sure you get the sessions you want, we encourage you to go click on that little plus sign. It'll turn it over to a check mark, and that'll make sure that your spot is saved for your sessions. And another secondary feature of Pathable that I just wanted to highlight is the Conversations tab. And you can use this like you would use a bulletin board at a regular, in-person conference, where you can post questions, comments, discussion topics that you're interested in as you're going through your different sessions, and also things like job postings, other opportunities that you want to share with everyone who's attending FIT. So it's really a place to just share general comments with all the attendees and the event staff. Finally, I wanted to share the Myfit action plan, which is a really great tool that we use every year. And of course, the first time this year that this is virtual. So we have a fillable PDF for you that you can download from Pathable. And this is a great place for you to articulate some of your goals for the meeting, keep track of those who you're meeting and some of the key takeaways as you're going through the sessions, just to really keep you organized and keep track of all those things that you want to remember after our 3 days together are finished. So now it's my great pleasure to introduce Liza Corso, Senior Public Health Advisor and Team Lead at the Center for State, Tribal, Local, and Territorial Support at CDC. We've worked closely with Liza and the CSTLTS team over many months to develop the FIT agenda, and it's been such a pleasure. We really appreciate your partnership. So Liza, I will turn it over to you.
Thank you, Megan. I am so excited to be here today and to welcome everyone on behalf of CDC. As you've been hearing from both Megan and Lori, FIT is a very unique training event that emphasizes practical skill building and interactive hands-on learning. And as you can see, we have a long history of supporting this training event focused on performance improvement. It extends all the way back to when it was a training focused on the National Public Health Performance Standards, tools and quality improvement actions that could be taken using those tools. It has continued to evolve and remain responsive to the field throughout the years. And this year, for the first time ever, we're really excited to understand how it will be to deliver this kind of training through a virtual setting. FIT is always planned and supported through a very strong collaborative effort. We work closely with NMPHI, who coordinates the event, and we also draw on insight and expertise from numerous other national partners. So I want to take a moment to recognize the individuals who have been so instrumental in making this training event happen. Now, if we were in person, I'd be asking folks to stand up and wave. But since we're virtual, if you can, and when I read the names of those involved in planning, please feel free to send a hello message in the chat. First, this absolutely would not have been possible without our partners at NMPHI, who have coordinated countless details as we've put together the agenda, coordinated with speakers, and transitioned to the online platform. You just heard from both Megan Wolfe and Lori Call, who spearheaded much of the planning for this event. I also want to recognize Layla Fox, Carmelita Mero, Melissa Jones, and Brittany Bunn. We also want to recognize other members of our FIT 2021 Planning Committee, many of whom are involved in moderating or delivering workshops throughout the next 3 days. So you may get a chance to interact with them, or you may already know many of these individuals. From the Association of State and Territorial Health Officials, or ASTO, as we know it, and of course, those representing our state and territorial health departments, we had Heidi Westerman, Amandeep Sandhu, and Marwa Fadlala. From NACHO, Sarah Weller-Pegna. From the National Indian Health Board, Sarah Price, Nina Martin, and Jessica Dean. From the Public Health Accreditation Board, David Stone. From the Public Health Foundation, Vanessa Lamers. And from the Public Health Learning Network, Lori Walkner. And finally, but most certainly not least, I certainly want to recognize my own colleagues from CDC CSTILTS, who also participated on the planning committee, Brittany Argetsinger, Sharice Walcott, and Doha Madani. So thank you to all those I just acknowledged. This absolutely does not represent the extent of the collaboration. There were many other individuals from these same organizations and others that have been involved in planning and delivering workshops, outreach to participants, and other areas of support. So we are very appreciative to everyone who has played a part. Each year, and in the spirit of improvement, as you've seen, how we like to evolve the training and remain responsive to the field, we evaluate FIT and we make changes to future trainings to better serve you. Given that you're an audience with an interest in performance improvement, we hope you all recognize the value of responding to our evaluations so that we can use this data to continuously improve. So let me take a moment to tell you about your opportunities to share your feedback. At the end of FIT on Wednesday, we will send a link for a full training survey to the email address that you used at registration. So please watch for that and take a few moments to tell us about your experience. It is especially important this year since this is our first fully virtual FIT, and we have included some questions to ask you about that virtual experience. We also want you to be aware of how to provide feedback on individual sessions in the virtual setting. Each skills building and deep dive session has a set of 4 quick questions to answer. You can see those on the screen, or you see some instructions for this on the screen. The questions will show up when the session starts, but please take time at the end of the session to answer them. As you can see from the steps on the screen, it's pretty simple. From the session landing page in Pathable, you'll click the polls tab, click answer to respond to the question, select your response, and then click answer to submit. And be sure to scroll down so you can actually see all 4 questions. Thank you in advance for taking time to help us to improve. And a special thanks to Brittany Argetsinger from CDC, who leads our evaluation efforts. And finally, in regards to all of those that I just recognized, please feel free to reach out to any of us if you have questions or want to connect. So now it is my honor to introduce Dr. Jose Montero, who is the director of our Center for State, Tribal, Local, and Territorial Support at CDC. In the interest of time, I won't read his full bio, but I want to really encourage you to go to the speaker section of Pathable, where you can read about his impressive experience, including his leadership roles that he held in the New Hampshire Department of Health and Human Services before coming to CDC to lead our center. I also want to make sure you know to put in questions in the chat. If you have questions for Dr. Montero, we hope to have a few moments at the end to pose some questions for him, and I'll moderate those as we see those coming in. So without further ado, I'll turn it over to you, Dr. Montero.
Thank you very much, Liza. Really appreciate the opportunity to be here. Good afternoon, good morning, everybody. On behalf of CDC, really, it is my pleasure to welcome you to this 2021 Public Health Improvement Training. As it has been said a couple of times, Laura or Liza, this is our first virtual offering of this training. We will see how it goes, but hopefully it won't be the last one. I want to thank each one of you for the work that you do every day to improve health for your communities. You're here today because you're interested in gaining new skills and systems thinking, accreditation, performance management, quality improvement, community health assessment, improvement planning, equity, workforce development. All of those topics are in the really rich agenda that we have for this meeting. Hopefully you will be able to make most of the sessions that you are interested on. And please be present on those sessions and engage. I know that many of us have this tendency to, we are on the computer, we are doing the email, we are in the live meeting, we are looking at the cell phones, and we lose a lot of this rich content and interaction with the others in the room. Being virtual is sometimes a challenge for a few of us. Please do everything in your power to be present, actively engaged, and participating in the different sessions that we have here for you. I hope that with that, at the end of this next couple of days, you will walk away with a new set of skills to take back to your organizations to continue to make a lasting impact on the health of the public. We have from here all levels of the public health enterprise. As Laura said early on, we have almost all state, tribal, local, and territorial represented here. We have healthcare, we have regional and state organizations, of course, the public health institutes from around the country, several different consultants and national organizations. We have many people from the CDC, but we have as well academic institutions and students represented here. It seems as if, to my last number, we have more than 600 people registered. This is really good, this is really great, this is really big. It is a challenge for the organizers, and I really appreciate all the work that they have done to make this a great meeting for all of those who will be attending. As public health professionals, we have all spent our careers working and planning and prepping for what's next and the big disaster. Well, we have gotten that catastrophe with the COVID-19 pandemic. The challenges that our public health community have faced in the past year have brought new trials, opportunities, and leverage points to this work. This pandemic actually laid bare the disparities of our nation. We have seen who has gotten sick, who got hospitalized at higher rates, who have been losing jobs, who has been more negatively affected by COVID-19. We need to improve our capacity and core capabilities in areas for whatever comes next in public health. But we know what is coming up now. In CDC Center for State, Tribal, Local, and Territorial Support, CSTOS, our priority is to support your work in the state, tribal, local, and territorial health departments. But we work with those other partners that are represented here in this meeting. We actually recently updated our strategic plan. And I want to share that with you because it's important for us to see where all of this fits, how we are looking at our planning, how are we, where every action that we do fits, where it goes and how we manage this. So I hope that you are seeing my screen now. Can somebody confirm?
Yes, we are.
Okay, good. I never know. My computer changes, so I have no idea where I am. So in this updated, we have included the traditional thing that you may expect us to have, right? We need to develop the science, we need to implement that science, we develop workforce and functional capabilities here. But as I mentioned before, the pandemic showed us how health disparities are affecting the populations we serve. So we went back actually and revisited our plan to include this in our work moving forward. You see this priority 5-year equity, diversity, and inclusion. And please, these numbers, priority 1, 2, 3, 4, and 5, are just so we know which one we are talking about. There is not a priority number 1 more important than the others. These are all equivalent. Those are at the same level. So let's look at here priority number 1, strategic partnership and stakeholder engagement. These few days here at the public health improvement with hundreds of participants from the agencies across the country, is one of the ways that we engage with our stakeholders. But we have national partners here. We have academic partners here. And this is the way that we help build the system. Because it's not about the SDLT agencies alone or CDC by itself. When we're talking about changing the system, we need the communities. We need the organization that represents them. And we need many other members in this framework. Now, this FIT is a well-recognized training. It's a premier training event that CDC has supported for many years. And it is one that I'm always excited to participate and welcome participants to. It is a shame that I cannot be on these different conferences. And it's one of the challenges that we will need to figure out with remote trainings. When we are in our offices, it seems as if we cannot set aside 2 or 3 days to be present. And I want to keep emphasizing that. Please be present. This is an amazing opportunity for all of you to develop the skills and the network that you need to have, that you want to have, to be successful in improving the health of the populations that we serve. Through your participation in this training, you will see that we are addressing priorities 2 and 3, the elite public health workforce and operational excellence on the health departments. So a couple of things with priority number 2. If you look at the agenda, actually at the end of the meeting, you have a whole panel session where you are going to hear about all of the efforts that we have going on right now, and maybe get some preview of how we plan to invest the billions of dollars that are going to be going into the system for workforce. Now, priority 3, we are supporting national accreditation for public health agencies, which is so important to building a high performance, high department with core capabilities. And you see the different goals there. Many of the workshops here are focused on training you in the very content of these national standards, including community health assessments, health improvement planning, quality improvement, performance management, partnership development. All of those are key for what we are doing. The session will provide you with information about the evidence-based strategies and what works. And tie that to priority number 4, which is the access to data and evidence. So you see how this training actually brings to life all of our strategic map. So when we go back to where I started, priority number 5, equity, diversity, and inclusion. We must put this at the forefront of what we do to ensure health equity is infused in all parts of our work in visible ways. I know that we manage language and we say, oh, we look everything through the lens of this. But unless we make it real, measurable, and objective, we are not going to do it. How many years we have been talking about equity, and look at what COVID shows. It is there. Now, I know that the public health system is not going to do all the changes that our society needs, but we have to be sure to be at that table where these discussions are happening with the skills of what people expect from public health, which is science-based, capacity to measure, capacity to follow up, and standardized ways to look at it, knowing that there are differences in every place and in every region. Across the agency, CDC is addressing racism as a driver of health inequalities through a range of key initiatives, including science and research, community programs, policy initiatives, workforce, and pipeline efforts. I'm encouraged and excited to see this health equity being incorporated in a more strong way into some of those major tools and frameworks we support. We actually have a new public-facing website called Racism and Health. Now, CDC's interest is parallel by work with partners, which is advancing health equity in many new ways. As an example, the revised essential public health services that were released last year now they have a health equity at its center. We anticipated this. It happened before, well, slightly at the beginning of the pandemic, but we have been working for this for quite some time. And we knew that this equity issue needs to come to the forefront, needs to be visible, needs to be there. So we also know that updated versions of the 5 standards and measures, the core competencies for public health professionals, MAP, community health improvement planning tools, are all in process. The new versions of these tools and frameworks will draw in health equity in a more strong, clear way. Lastly, I know that many of you are performance improvement professionals, and I'd like to talk about how accreditation, quality improvement, and other performance improvement strategies have been of great help in response to the challenges that we all have faced over the last 15 months. In the current landscape in which public health is operating, pandemic response, pressures on public health, increased emphasis on equity and combating disparities, the burden on our workforce, and the political pressures, everything is tighter than it has ever been with our leadership and our workforce. And you have experienced this in your local, state, tribal, and territorial health departments. At the same time, we know that those accredited health departments consistently report positive impacts from accreditation. But perhaps more importantly, more than 80% of the health departments indicated that overall accreditation has helped their response to the pandemic. Over the next few days, you will each have the chance to hear more about accreditation. And that is, it is incredibly important that you hear that you look at it, that you consider it in your context, because it is a quite valuable tool. And you will hear updates from FAB about national standards. We will also hear from health departments that their work in community health assessments and community health improvement plans help build community relationships. Our response was not built overnight. Community health assessments, community health improvement, the engagement with the community, the capacity of that community to listen and engage with you didn't happen because of the pandemic. It happens because you have been working on this for quite some time. I want to share a quote, and I'm going to read it. The FAB health department stated that, let me look at this. Working on the social determinants of health has helped in responding to community needs during the pandemic. This has all built up our credibility as well, which has helped the city trust the health department to lead in emergency response. The work that we do every single day is the work that we rely on when we have the emergencies. Our credibility and image is what we bring in the emergencies. Having been responsible for looking at this standard for quite some time, give me the confidence that we are moving in the right direction. So, national accreditation standards require that health departments meet standards accrediting preparedness, planning, and protocols. This is critical. So we improve because we meet the standard for preparedness, but we improve because we meet the standard for community engagement, for data gathering, for improvement in general. So using quality improvement or QI expertise and tools help plan to improve COVID-19 testing or vaccination clinics, and we have seen that. So you have been conducting more QI all across the response. Much of your work, again, engaging with communities, with public health system partners, with your own organizational staff, has had to move to virtual environments in unexpected ways. This meeting, you have conducted virtual community health assessments, community health improvement planning, virtual QI trainings. This is our first virtual fit with more than 600 people registered. And what made this incredibly important and successful is that we got more registrars, people registered from small local health departments and tribal territorial settings than ever before. Maybe the issue not need to travel was, but the fact that people is today registering for quality improvement tells us that people really know and understand how we need to standardize and be careful in how we monitor and manage our day-to-day. Those are the tools that we hope you can learn or refine here. So I will finish with thanking each one of you for all the important work that you do each day. How you brought all that work to a response that was unprecedented in our times. Hopefully we won't have to go through one of these again in our lifetimes, but we need to create the systems that are ready for that. We need to make sure that toward the future, we are bringing up and implementing the lessons learned in such hard way through this pandemic. The disparities, the focus on equity, the need to be all on board for these different needs is more clear than ever. Of all of the people that we have registered at this event, I mentioned before, it's not just state, territorial, local, and tribal health departments, but our partners, the public health institutes, the academics, the academicians, students. We all need to get in this together because it's the only way that we're going to improve our roles as quality in highly performant professionals. So thank you very much for being here. Great luck with this training. Hopefully we will learn lessons in this training and use them for the next iterations, because the remote platforms offer advantages that we didn't see that clear before. Let's learn together. Thank you. Back to you, Liza.
Thank you so much, Dr. Montero. That was just inspiring and setting us all up on the perfect note for what we hope is a wonderful 3 days of learning, all from each other. We do have questions flowing in. We probably only have a moment for one or two of these questions. Acknowledge, I see some questions such as a question about QI reports or storyboards available for quality improvement efforts around COVID-19, and where can they be accessed? We can actually probably try to share some of that through the Pathable chat. So let me focus on questions that we'd love to have you answer right now, Dr. Montero. From Leanne Klein, there was a question about how, well, she says, will additional funding be funneled down to the locals? And will there be additional funding earmarked or made available to support accreditation, and I'll just add, or public health infrastructure efforts?
So we have new funds coming that, well, actually already awarded last week for disparities work, $2.25 billion that will be available for many health departments across the country. 107 applicants are going to share that funding and work on it for the next couple of years. That funding, actually, it is, because it's an appropriation that came from Congress tied to COVID-19, links a lot about community engagement, improvement in testing, access, vaccination. But those health departments actually read that there is a lot there to build the right type of infrastructure for addressing disparities. And we have been categorically clear on that. How they build it, what tools they develop, who do they engage with, we are actually leaving it incredibly open to the applicants and how they work at this. It is a grant, not a cooperative agreement, which gives a lot of flexibility to the awardees to implement that at their level. We don't have any other current funding that will go to help support the localities in applying for accreditation. But then again, we as a system have a problem that we never had before, which is the incredible amount of money flowing to you. So we talk about $20 billion that went through the ELC. We are talking about 5 or 6 billion. And I know that people in our system don't believe that. Last year, we were fighting for millions with an M, and I hope that you are not getting confused with my accent. But I am talking about billions with a B. If we cannot lead these at the health departments in ways that we identify what pockets of funds we need for what and move around things in ways that are legal, but that respond to our needs, we are missing the call of leadership and the boat. We need everybody to get in their thinking creative ways. What can I get with this funding? What can I get with this funding? What can I get with this funding to achieve this overarching objective? And that is where we need everybody there at the table, knowing that we are trying to solve a big issue with these health disparities. And what do we need as a health department to be ready to do that? That is the question that you will need to answer in each one of your jurisdictions.
Thank you so much. We have one more question I'm going to pose to you, but I'm also going to before we transition to Dr. Nafissa Egbuoyne. From Wendell Harden, how does CDC bridge the understanding of equality versus equity?
We are working in many different aspects of these questions. Actually, right now, we have agency-wide effort, building our common understanding, bringing together all of the different efforts that we have had over the years. So it's not that we have not been working on equity and equality. We have. But as the person asking the question highlights, there are different understandings. You look at all of our work in tuberculosis, all of our work on HIV, addressing an epidemic that is affecting mostly Hispanics or African Americans, and we look at obesity. And all of those in general look at things in populations of higher need and disparities. So how do we bring all of this together? What is the common denominator? And we are building the core of our understanding of our own agency-wide science agenda for health equity. We are not ready to come public and present and get your input because we are trying to collect internally what we need. So I don't know if I actually should be mentioning this today or if I am going to be get my hand scalded here. But we are working on that. Hopefully by August, we will be able to come public with some of this work and engage with the field in a more open, cohesive, and wide way.
Thank you so much, Dr. Montero. And thank you for your inspiring remarks that have, I think, perfectly set the stage. With that, we are going to transition to our next speaker. And Megan, I believe you are going to do the honors of introduction.
Yes, thank you, Liza. So I am so pleased to introduce Dr. Nafissa Cisse Egbuoyne today. She's the director of the Black Hawk County Health Department in Iowa and our keynote speaker. Since joining the agency in this role in 2016, Dr. Egbuoyne has established her department as a leader in health promotion, prevention, and health equity. Today, Dr. Egbuoyne will speak about the dual pandemics of COVID-19 and racism in her community as catalysts for public health transformation. Dr. Egbuoyne, welcome, and thank you so much for joining us.
Thank you. Thank you so much for having me. And thank you also to Dr. Montero. What an inspiring speech. I'm very passionate about public health. And so anytime I hear the same passion, I get very, very excited about our future, and it gives me hope. So with that, I put in the chat so 3 questions that have been on my mind since I was asked to be a keynote speaker. I'd like for the attendees to just take some time as I present my talk to answer these questions. But these were really questions that I had in mind throughout this past year. The first question is, how do our values and beliefs shape who we are as individuals and influence our behavior? The second question is, what does power have to do with fairness and justice? And the third question is, what is community and what are the individual's responsibility to the community as well as the community's responsibility to the individual? Again, good morning. And as Dr. Montero also said, good afternoon, depending on where you are. For me, it is truly an honor for me to be among you all. I'm really filled with gratitude to have the opportunity to share my thoughts about public health and the work of Black Hawk County Public Health. And it's just such a delight to be among public health practitioners and academics and students. I've received some messages from students already. I will do my best to respond to you as promptly as I can, and I will respond. So do know that. So with that said, over the past 16 months, the COVID-19 pandemic has not only challenged the public health sector, but it has brought to the forefront the biases, discrimination, and racism embedded in our society. COVID-19 has severely impacted our lives. However, communities of color belonging to the essential worker class were devastated the most. People of color were disproportionately had the highest number of deaths due to COVID-19, have the lowest access to health care, the highest rate of unemployment, and their children face education challenges, limited access to adequate nutrition. We all know as public health practitioners, as even non-public health practitioners, that it was not genetics that made communities of color more susceptible to COVID-19. It was their social, economic, and environmental conditions. Unfortunately, as a practitioner, I've come to understand that as human beings, instead of embracing our differences, we have constructed a standard in our society that does not allow everyone to be appreciated for their individual humanity. We created categories. We divided people into subgroups. We have constructed a standard for who will belong and who will not, who will have access and who will be denied, and who will win and who will lose. Today, the coronavirus pandemic, systemic racism, and the inequities in our built environment present unprecedented challenges for our society and the field of public health. In 2016, Public Health 3.0 called on health departments to go beyond the traditional field of public health. It underscored the need for health departments to expand and strengthen collaboration with non-traditional partners to implement strategies, initiatives, and/or policies that explicitly address the social determinants of health. And as Dr. Montero just presented, in 2020, the 10 essential public health services were revised with a strong focus on equity. And just recently, NNPHI's most recent report emphasizes the importance of infusing equity into all aspects of our work and embracing the challenges and opportunities for strengthening the public health infrastructure. So what does that mean for all of us as practitioners in the field? So it is my belief, and I think this is also a collective belief, that to succeed in health equity efforts, the public health sector will need to infuse cultural humility into operational practices, not cultural competency. As Dr. Mentor, I heard him mention about languages. This is not talking about cultural competency. This is talking about cultural humility. In committing to cultural humility, we hold our organizations accountable to our institutional biases. Cultural humility allows us to adapt our policies, procedures, and programs to meet the needs of the diverse population we serve. Cultural humility is critical to health equity. So here in Black Hawk County, a population of approximately 131,000, the city of Waterloo is home to the largest African-American community in Iowa. And if for some of you all who might know Nicole Hannah Jones, Waterloo is her birth home. The city is also home to a vastly diverse immigrant and refugee population, and more than 60 different languages and dialects are spoken in Black Hawk County. The health department applied cultural humility by seeking to understand our community members' background and lived experiences. It was culture, humility, and community engagement that helped us to mitigate a COVID-19 outbreak at a major meatpacking plant. So during the outbreak, we received calls from community leaders and members who informed us of the situation inside and outside of the plant. They shared with us their barriers to testing, their fears of losing their jobs, and their fears of dying. Yet in the midst of their struggle, they also offered to help the health department and the overall community. They asked us, what do you need us to do? How can we support? How can we help? Their communication and action made it clear that they felt heard and seen by the health department. They knew we were in this together. So for us, in order to dismantle oppressive system, as public health practitioners, we must build meaningful and trusting relationships with our communities. Our programs need to be connected to the grassroots and not just the ones that are traditionally recognized of as community-based. So don't assume they're not people organizing. Maybe they don't have, a typical community-based organization, but collectively their voice matters, and they do consider themselves to be community-based. So not just the ones that are traditionally recognized as community-based. Including diverse perspective in meaningful, actionable ways will not only increase the sense of belonging, but the acceptance experience across the community. We believe that when people and communities move beyond this obligatory inclusion, right? So I'm just attending a meeting because I have to. No, we want people to say, I want to attend this meeting. I want to be part of this cause because it's important to my value. It's important to my belief, right? So when people and communities move beyond obligatory inclusion to deep belonging, true co-creation towards a more equitable community is possible. We believe this will lead to stronger, more stable social networks and the reduction of the divisive mentality. Shifting these dynamics will impact the drive to tackle equity issues, participation in public programs, reduce poverty levels, and poor health outcomes. In addition to cultural humility and community engagement, our workforce needs to understand the historical and ongoing ways in which structural racism is institutionalized in our community. It is imperative for health equity trainings to explicitly teach the impact of slavery, violence, and segregation on the lives of Black, Indigenous people of color. We have to connect the past with the present because this is what allows us to be more effective agents of change. People need to understand where we were in order to move forward. So an example of that, in 2018, the two largest cities in Blackhawk County, Waterloo and Cedar Falls, were labeled as the worst place for African Americans to live. This was due to disproportionate gaps in income, unemployment, and home ownership between white and Black Americans. While the 24/7 Wall Street was at once deeply troubling, and yet inherently known, Blackhawk County Health Department felt it critical to act upon the information. Sometimes, when there's bad news, I believe that this is an opportunity for health departments to step up. How do we utilize information that is disheartening to make a positive change in the community? So we deliberately assume the role of health equity strategist for the community. In partnership with Engaging Inquiry and the Midwestern Public Health Training Center, we hosted a series of systems thinking workshop with the health equity perspective and included our staff of 60 and 76 external community partners. The stakeholders included representatives from the healthcare system, regional and city planning, education, economic development, the faith community. We had traditional and non-traditional community-based organizations and government leadership. We engage our community to discuss and map the current inequities within the community. We wanted to get a sense of what do they understand as it relates to equity. When Dr. Montero talked about CDC trying to achieve that common understanding, for us, it was important as a health department to lead in the common understanding of the inequities in our community, but not just the inequities, but also the equity related things that were working. So we asked the community what accounts for the level of equity within our community, because we wanted to know what's working and what's not working and what is really their understanding of equity. So we also increase the awareness of the historical and systemic foundations of the inequities. I remember showing a redlining video, and a staff member said, "Why is it at 30 something years old, I'm just learning about redlining? This is unfair to me." And so that to us was it just highlighted the importance of our work and the importance of infusing history, right? So people understand the historical nature of this country and our societies and why the inequities exist in the first place. So in addition to reaching and engaging the community, we also launched an agency-wide health equity training curriculum. And we were very honest with staff. We said, this is a pilot with a Midwestern Training Center. And at the end of the day, it might be messy, but we have to start somewhere. And that is the thing with equity work. You have to start somewhere. You can be in communities where that, especially in rural communities that are more homogenous. But what does equity mean to rural communities as well? You have to start somewhere. The conversation needs to start somewhere, even if it is messy. So these important introspective conversations could not have come at a more important time for our community. We intentionally brought our community and staff together so they can see themselves as a connected, powerful system, a system that is capable of fostering transformational change. Today, the pandemic and the politicization of public health has taught us how essential it is for our public health infrastructure to be effective and strong. As public health practitioners, we are now challenged to look beyond ourselves and pay close attention to our areas of unawareness. You know, as a person of color, very often, I think that I'm aware, but these days I'm being more intentional about the areas of unawareness. And so I do this thing where I practice zooming out and zooming in and zooming out, because I have to ask myself, what am I feeling? What am I understanding of the system? What's happening? How am I engaging different groups? What am I hearing? What am I sensing? What are they hearing? What are they sensing? You have to constantly ask yourself. So as Dr. Montero said, being in the moment. To be an effective public health practitioner and to be able to address health equity issues, you have to be in the moment, because the system is moving at all times. And so be aware of the areas of unawareness. So we know today that the current inequities in our society is not just caused by bad actors. We know that. This current system is perfectly functioning to maintain the status quo, to reinforce existing power and privilege, while further harming large groups in our communities, bringing forward distrust and hopelessness, and creating an environment of conflict and polarization. Furthermore, when the system is faced with resistance, because it is designed to maintain control, it responds with a swift, punitive response, specifically for communities of color. This shows up as the disproportionate percentage of people of color deemed as essential workers who are asked to continue to work, potentially exposing themselves and their families to COVID-19. This is also demonstrated as African Americans disproportionately bear the burden of aggressive policing. So this is why it's so important for public health to not only be at the table, but to step up and lead the conversations, the critical conversations and actions towards a transformational systems change. Today, more than ever, we know that our societal issues are fluid and complex. Hence, for public health to thrive and ensure that everyone has the opportunity to achieve their highest level of health, we will need a workforce that is adaptive. You know, I came here in Iowa a few years ago in 2016. There needed to be a lot of change. You know, as a newbie coming from academia, I was like, oh my goodness, how do we implement all this change that needs to happen and also ensure staff that, you know, this is so important, right? And so I learned that it's so important for staff to engage in change management, to be adaptive, to understand that when we start doing the same thing status quo, there's something going on that needs to be changed because our system changes, our system moves and shifts rapidly, and our system is adaptive. So we need to become more adaptive with our system. So infusing adaptive strategies into practice provides a steady but meaningful process of change. While COVID-19 has highlighted gaps in the public health system, we have learned and we have shown our nation that implementing innovative strategies to meet the needs of our community is necessary. We know that we can no longer afford to treat adaptive challenges with only technical solutions. We must be able to embrace and make sense of the complexities of our system. We must be able to do that, you know, and adaptive strategies coupled with the systems thinking approach will give our workforce a deeper understanding of the dynamic relationships and patterns within our system. So the field overall, as Dr. Montero talked about this, is that the field of public health, we need to gain a collective awareness of the whole system. You know, one of the things that I've learned as a practitioner also is that organizationally, you know, we have, you know, siloed programming, right? And sometimes that's not our own doing. Sometimes that is because it is how we're funded. But we need to also be more willing to try and change and model, you know, for our staff and our programs, you know, how to have that collective awareness of the whole system. You know, the issues that are happening in environmental health, how are they impacting chronic health programming? How are they impacting infectious diseases? So those are kind of things that we need to become more aware of. So the elements that make up the whole and the way the elements interrelate with each other to cause the system to behave in the way that it does. So this collective understanding will lead to the uniformity in the systematic assessment of policy, programs, project, and planning decisions that have a significant impact on population health outcomes. This past year, I've learned that to be an effective systems leader in public health, we need to seek health, not mission accomplished. See patterns, not just problems. Unlock change, but don't impose it. Plan to adapt, don't stay the course. I end my talk by once again expressing my gratitude to you all. I know in my heart we believe that health is a human right, and we are entitled to optimal health and security regardless of our race, culture, and social economic backgrounds. COVID-19 and the disparate treatment of Black Americans in policing has highlighted that our time is up. Our time is up, folks. You know, this is the time in our field where our hearts and minds need to be connected for the betterment of our society. As public health practitioners, we have an obligation to collaborate to solve complex problems and fight racism. Fight it like hell. We need to fight it. We must also join efforts and bring about human connection and reframe the divisive social, cultural, and geographical rhetoric we hear today in our society. By doing so, my hope is that we can find common ground and can achieve quality of life for all people. Public health improvement training FIT is already taking the step by putting us together in order to think critically about health, equity, and health. This is the place to be empowered by the many and diversified actions that all of you are taking at your workplace and communities to make health equity a reality for all. I thank you all for sharing your knowledge and experiences. And as Nelson Mandela once said, a good head and a good heart are always a formidable combination. Thank you.
Thank you so much, Dr. Egbuoyne. We have so much gratitude for you, to you for kicking off the conference. That was, you've just brought so much energy to our morning, and we so appreciate you. There has been in the chat here in Zoom and also in Pathable, a lot of yeses, a lot of me too, a lot of I hear you. So it's been very affirmative as you've been speaking. We have 3 questions so far. If you have a few minutes, I think we'll take about 10 minutes to do some questions. So the first question is from Camilla. Do you know of any good cultural humility trainings for staff?
Ooh, that's a great one. That's a great one. So as I shared, it's messy work, right? So it's, cultural humility here, what we're realizing in Black Hawk County is that it's how to teach people to be more comfortable in asking questions that they are not aware of, right? Because we come from we live in a segregated society, we see that people just, they come to work, they leave, and then they are in their same circle of friends, same circle of family, and you don't even know this new neighbor that might have a different background, right? So how do we start teaching people that it is okay to approach people? It is okay to have coffee with that person that is different from you, and have a meaningful relationship. So there's not necessarily a specific training that I would recommend, but I do know that we are doing this with the Midwestern Public Health Training, and we hope to share that with you all. And so when we finalize some of our work, we'll definitely, share with anybody. We will have it on our website so that people have it accessible.
Thank you so much. And some trainings have already been shared in the chat, I think, back in Pathable. So I think there's lots of great stuff coming out related to cultural humility. So a question from Agatha, can you talk more about the accountability mechanisms that local health departments can leverage to ensure that our actions align with our ideals and mandates?
Ooh, so that one's a hard one. We've seen it with COVID. We have seen it with COVID, how especially when it comes to enforcement and our mandates, it's been very challenging here. I'll share with you all here, for example, the Board of Health, in collaboration with just, a wide variety of community support, the NAACP, the overall community at large, passed a mask mandate. However, that didn't move forward with our Board of Supervisors. And so we're seeing that. But I think for me, one of the things that I've learned also is that when we talk about equity and we talk about going back to the root causes of the inequities in our society, we also need to engage our community to better understand their political leverage, right? And so understanding why it's important to pay attention to who is on the ballot, and why that matters. Because we have communities here, we have immigrant and refugee communities here that, for example, are citizens, right? They have the right to vote, but we've realized they're not as politically engaged. They lack an understanding of our political infrastructure. So I think that also it's part of public health's responsibility, if we're really intentional about being social justice and human rights oriented as a field. We also need to educate people on the political infrastructure of our communities, so that when issues such as in mandates and enforcement, I think there's more accountability there, at least at the community level.
Great, thank you for sharing that. Yeah, I think the issues of power and how communities can get more of it, I think, yeah, that's great. Thank you. Two more questions for right now. One from Amanda. She shares that she works for a local rural community, a small rural community, and has to work within the parameters established by the Board of Commissioners, who may not recognize health equity. She asks, how do I move the needle forward? This includes not approving grant funding for health equity work.
Mm-hmm. So one of the things that I've learned in engaging different leaders in our community, when we talk about don't impose it, it's about meeting that person, understanding what they value. And it is going to be hard, but it's going to be our responsibility to connect that value to health equity. So I think that's one of the things that we have struggled with, right? Because we understand it. And so, I'm always like, why not? This is great for everybody. So what's the issue, right? But in reality, people have different values, and some are economic values, right? So how do we tie economic values to health equity, right? Population health outcomes, right? So when I talk about the outbreak at the meatpacking plant, I also realized that our businesses were becoming a little bit afraid. What is the health department going to do to us, right? And immediately, being a part of the Chamber of Alliance here, we call it Grow Cedar Valley, we had a meeting with our businesses so that they understand our first responsibility is to educate. Let's partner so that we do this right? So I think that, even from a business perspective, it's like making sure like we understand how important the economy is to our communities. But if you don't have a healthy workforce, it doesn't matter. So how can this be a win and win for us collectively? And so I think that that's going to be one of the key things is going out to people, understanding what they value and connecting that to health equity.
That's great. Thank you for sharing that. Leanne asks, what has been your biggest challenge in your current role addressing this topic? And that could be racism, COVID, both. Up to you, but your biggest challenge maybe in the last year.
Yes. So my biggest challenge, and because we're establishing vulnerability in our workforce, I tell staff, I don't want this to be because Nafissa is a Black woman. I don't want that. For me, it's been, that's what I've struggled with, is, are people going to think this is my own personal agenda because I'm a person of color? And so I really engage myself. I don't pull, I withdraw myself with some of the training so that people, staff can have a space to be vulnerable and to have those conversations. But my message is that, health equity should be in the walls of this agency. So regardless of who's sitting, if it starts to shift in a different direction, the people, the workforce can say, this is a red flag. We need to do this differently.
Great. Yes, laying the groundwork already. That is so great to hear. So Antonia asks, in addition to cultural humility training, how are folks getting practice with cultural humility? She says, learning labs, affinity groups, are there other ways, sort of as you're talking about cultural humility with your staff, how people can practice?
Yeah, I think, even internally, it was like, there was a need for a sense of belonging. You know, I heard staff say, well, I don't know people in the 4th floor. I don't know people on the 5th floor. And so we've been intentional about creating wellness activities so that they learn to be with each other, right? To get to know each other. Because if we can't do that internally, how are we going to do that externally, right? And so it's always been like, this year, these next 2 years, it's all about internal work so that we are better equipped to be leaders and this health equity strategist externally. And so it's really, I mean, in some of it has to do to shift the mindset of, you know, being at work. It's like you come from 8 to 5 and that's it, and you just are on the computer. No, there needs to be a time for wellness and camaraderie and building those relationships internally.
Yes, I think we're all looking forward to getting back to that at work and
Yes.
elsewhere. So thank you. All right, one last question, and then we will let you go. I know you're so busy. So Laura asks, can you elaborate on generational aspects? So maybe some of the ways that you know, different generations are dealing with these topics, maybe both internally and in the community.
Yes, yes, and we're seeing that. We're seeing that. Again, most important is to create the space. You know, for me, I think it's been one of those things that, you know, ensuring that your staff feel comfortable enough to ask a question where, you know, they're wrestling with it internally and might feel like, I'm not going to ask to so that I don't offend, right? But if you don't ask, we won't know how to address it, right? And so we're being intentional about that. It's not easy. But the second thing, I think that for us here, what we're seeing in rural societies is that there's this divisive mentality, you know, of the experiences of the rural poor and communities of color. So it's like, so we asked the question, well, why do rural poor communities, rural white poor communities have this concept like you have to work harder, when there's actually programs that help to support some of the struggles that they also experience, right? And so really we say that our story starts with this us versus them mentality. And that's what we see here when it comes to the generational mindset, is that, well, I've had to work really hard to where I'm getting at. What do you mean by white privilege? Well, let's discuss this even further, you know, and see where we have the commonalities and also the differences, and also when does privilege show up?
Thank you, Dr. Egbuoyne, so much for joining us today. I think
Thank
we
you.
all learned something on all different areas of our equity journey. So we so appreciate you coming today.
Thank you. Thank you. Thank you, everybody. Thank you.
Thank you.
Mhm.
All right, Carmelita, I'm going to go ahead and turn it over to you to close out our session in the last few minutes.
Sure. Thank you so much. Boy, that was such an inspirational start to FIT. We will begin our skill building workshops at 1:30 p.m. Eastern. So you'll need to leave this webinar, the Zoom webinar, and go back to Pathable, your virtual conference site. Click on the schedule tab and then my agenda, because we've encouraged everyone, right, to add sessions to their agenda. Click on my agenda and go back to the session that you've added to your agenda. Click into the skills building workshop session, and you'll be able to then access the session within 1 minute of the session start time. So enjoy your few minutes here, get a drink of water, stretch, and we'll start again at 1:30.